Health. Thank you for joining us today on this topic on federal policy 2024 and beyond. We'll cover rural healthcare delivery, including some behavioral health information. I'm Molly Kremak. I'm the program coordinator for the RIP team, and I'm here along with our program manager, Rhonda Barkis, and our program specialist, Angela Flam. And just a few housekeeping details before we get started. Your audio is muted by default when you entered the room. Please remain muted through the presentation, as this will help eliminate background noise. And we'll have a couple spots for questions. Feel free to add questions to the chat box. I'll be taking a look at that. And then we'll have a couple of Q&A spots, of course, Q&A at the end. So some information regarding webinar expectations. We'll have a couple of pre and post polling questions. The first we're going to pull up in just a moment. And if you would remain on through the end of the call, we'll have some post questions that would really help us out if we get your feedback. Then we'll also provide you with a link to our short online evaluation after the webinar. So if you'd like one ACHE qualified education credit, an evaluation will need to be completed. And we can go ahead and pull up our first polling question. Okay, you should see that on your screen. The first question being, I'm confident, somewhat confident, etc., in my understanding of the current political and policy dynamics in Congress and the administration that affect rural healthcare and behavioral health. If you scroll down, there's another question. I'm confident, somewhat confident, etc., in my ability to recognize how policy changes and priorities anticipated post-election could impact rural healthcare providers. And I'll give a minute for responses. And just a little bit of background on the RIPT project. The RIPT project is supported by the Health Resources and Service Administration and the Federal Office of Rural Health Policy. And Janine Myers is the RIPT project officer. Then our purpose and goal. So the RIPT purpose is designed to help strengthen organizational foundation and the key elements of value-based care, including but not limited to quality, patient experience, and safety of care. The goal is to guide small rural hospitals and certified rural health clinics not currently participating in value-based care through advanced alternative payment models to prepare for and position their organizations to be effective participants in a health system focused on value. We'd also like to share that we're currently accepting applications for the 2024-2025 cohort. Applications actually close tomorrow at midnight. So if you're a small rural hospital or a certified rural health clinic, or if you know of any organizations that would be interested, please forward out this information. So just one more day to apply. Technical assistance for this project year will begin in November and then will end in August of 2025. Then we'll have more information. Oh, I'm sorry. We had an informational webinar back on July 16th. I'll also share information. There's a playback if you need more background information on what the cohort would look like, what expectations are. You'll be able to access that on our website. And now I'd like to welcome today's speakers. We have Julia Harris and Kendall Strong, both from the Bipartisan Policy Center. Julia Harris is a director for the health program at the Bipartisan Policy Center. Prior to joining Bipartisan, she was a director of clinical models for United Healthcare's Medicaid managed care business. For 6 years, she worked for TennCare, Tennessee's Medicaid program, leading value-based payment and delivery system reforms, including developing a novel statewide health home program for members with severe and persistent mental illness. Harris joined the state of Tennessee after holding previous positions with the Kaiser Family Foundation in Washington, D.C., and a large federally qualified health center in New Jersey, where she led a team of migrant and community health outreach workers. In 2017, Harris was a part of a small team that took up top prize in the global Qualcomm Tricorder X Prize competition to build an innovative consumer medical device. And Kendall Strong is a senior policy analyst with Bipartisan. Prior to joining, she served for 5.5 years with Congressman C.A. Dutch Ruppersberger from Maryland, who was a senior member of the House Appropriations Committee. In this role, she was responsible for managing a wide portfolio of issue areas, including healthcare, social welfare, housing, and education. So thank you both so much for speaking today. We're really excited about this topic and what you have to share. I am going to pull up your presentation, so just give me a moment to switch screens.
Awesome. Thank you. Well, I'll just jump in. Thanks for the invitation from the National Rural Health Resource Center. We're excited to be able to do this presentation today. Thanks for inviting us. Kendall and I have been working together for a couple of years now and wanted to divvy up the presentation in a couple parts. So overall, I think we want to talk through, what are the current federal dynamics at the federal level in Congress with the administration, what might be implications for the upcoming election in a couple major areas. And so we'll get into it. Why don't we go to the first slide? Oh, well, that was my welcome, so we can keep going. So just a little bit about BPC. BPC is an organization in DC. We're a think tank, and we really are the only organization that works exclusively on to create bipartisanship on policy issues. And so for that reason, we are often seen as a trusted source of information among policymakers and folks in the administration. The other thing that makes us unique is that we do also have a 501c4, which is a lobbying arm, and that's our folks at BPC Action. And we work really closely with them to actually advocate for the policy positions that we think should be advanced. And part of why I love that, and I've worked in other think tanks before, is that it really does become a set of policy recommendations that don't sit on a shelf. Like Kendall and I spend a lot of time with policymakers in their offices trying to explain some of these dynamics and really do a lot of education and outreach with Congress and the administration to push these policies forward. So we'll talk a little bit about the dynamics, and then we'll also get into some things that BPC is working on and where we see some policy recommendations that we are advocating for. So next slide. All right, so I think we went through a little bit of this, but just again, we're going to talk through the current political dynamics in Congress and the administration that affect rural healthcare. We're choosing a couple areas because this is a big space, but including, I'll touch on some behavioral health issues, especially around telehealth. And then we'll talk through the dynamics around telehealth, and MACRA is what Kendall will cover, and thinking through how some of the anticipated changes with the election might impact both of those areas. Next slide. All right, so these are two big topics for today. Telehealth is a top issue for Congress this year. The Medicare flexibilities that were allowed for during COVID they were extended for 2 years, and there's coming up on another expiration at the end of 2024. So that's a top issue for Congress to deal with this year. MACRA is a top issue for Congress next year, and we'll talk a little bit about that. And I think no matter actually what the outcome of the election, I just want to flag that these are top issues no matter what, no matter who wins in the fall. And another nice thing, actually, just to flag for folks, is that generally, like rural issues and behavioral health issues are also very bipartisan policy priorities. So both, we talk a lot about these as issues with Republicans and Democrats, and there's a lot of opportunities for overlap in policy priorities in this year and next year. Can go ahead. All right, so telebehavioral health and telehealth. We'll get into, next slide, the federal policy landscape. So you may or may not be tracking on this. I don't know from where you all sit, but the federal the extensions for telehealth flexibilities are expiring at the end of 2024. There are current proposals in Congress right now to extend and maintain the current flexibilities through 2026. So to punt essentially for another 2 years. Key committees in the House and Senate, both very interested in extending these policies, and they have proposals with very minor changes to what is currently allowable. So I very likely expect that these will pass. Something will pass to extend the flexibilities for another 2 years. Because that hasn't actually happened yet, the administration has to kind of keep their own schedule of releasing proposed rules and finalizing rules. And a lot of what they bake into the 2025 physician fee schedule is because Congress hasn't acted yet, it needs to catch up to what will eventually happen, hopefully by the end of this year with Congress, likely in the lame duck. And so the 2025 physician fee schedule proposed rule is out. It does some interesting stuff, but it's not all the way where we expect it'll land in the final rule, because the flexibilities haven't officially been extended by Congress. One interesting thing that the administration has done in the proposed rule is make permanent the audio-only telehealth flexibilities. Taking a step back, and I will get into this in the next couple slides, but one of the biggest continued uses of the telehealth flexibilities has really been about delivering behavioral health services. So mental health and substance use treatment remain one of the highest use cases for telehealth services, and audio only flexibilities. Then thinking through, the reasons for why we have access to audio only or have had access to audio only telehealth, really not just unique anymore to rural America, but also just accessibility issues in other parts of the country as well. And even though I think the dynamic in Congress has been that we don't really know, the dynamic in Congress and among researchers is that we don't really know if the quality of audio only telehealth is as good as video visits for the same visit, I guess, to reuse my word, but for the same issue that you're coming into as a patient. But what we are weighing within at BPC and what Congress and the administration are weighing is that actually, because of the barriers to care that folks who have accessibility issues, either in being able to get the video to work or even just broadband issues and accessibility to internet in general, that audio only is going to be a permanent future modality going forward. And so that's a big change. The next big change in the federal policy landscape has been around the DEA. We're waiting for DEA to put out a new proposed rule around controlled substance prescribing. This has been anticipated for a long time now. And so we don't have a good sense of, at this point, I would have said would have already come out, but it's still pending. And what that proposed rule is expected to do is really change or maintain what are the current flexibilities around in-person visit requirements before you get prescribed a controlled substance via telehealth. So before the pandemic, that was standard that you had to have seen a provider in person before you get a prescription for a controlled substance. Since COVID, that has been relaxed, and there's dynamics on both sides about why that flexibility has been a huge improvement in access to treatment, especially for MAT services or for buprenorphine. And then there's other substances where there may be more, concern about creating sort of broader accessibility to other controlled substances without that in-person visit in the first place. So DEA will be setting out, currently the rules at this point are to have, they are as they were during the COVID pandemic. So they are very flexible without the in-person visit requirement. And what's anticipated is if DEA will put out any new guidance this year to change that. All right, let's go to the next slide. And honestly, folks, if folks have questions, I think you can either save them to the end or put them in the chat, and you can just let me know as they come up, okay? So just to dig in a little bit on what are the areas for policymakers that are focused on, like what are the, the dynamics that are coming up that are receiving the most airtime as they're making these decisions around telehealth flexibilities going on into the future. And as I said before, we say telehealth flexibilities, but in all honesty, the vast majority of that is accumulating into behavioral health services. So, a lot of telehealth is actually behavioral health care at this point. And the way that behavioral health services have been delivered in this country, the most dramatic shift to the behavioral health care delivery system has happened because of these underlying changes to telehealth, flexible, audio only services and telehealth policies. So the entire delivery system has really shifted for behavioral health care to be more virtual than ever before and that is not true for other services. They just don't lend themselves, primary care, eventually you got to come in and have a vaccine. There's other services that, certain types of visits have transitioned for other services, but nothing has transitioned to this virtual world, this virtual platform, the way that behavioral health care delivery has transitioned. So of the areas of focus for policymakers, I'll just touch on a couple here. Reimbursement continues to be a big question. We are currently continuing the policy that all, at least within Medicare, that all reimbursement is at parity with an in-person visit. So this is changing for, as I understand it, for a lot of commercial payers, but for federal payers or for Medicare, this has been consistent. And this is one of the questions on Congress's mind about, with that extension, if it is paid at parity, how do they pay for that change? So in more recent CBO scores, I think, those account for, at least back of the envelope, accounts for some small, because of the telehealth flexibilities existing, that they are also coming along with small increases in healthcare utilization and cost. And I think actually the fear or the expectation among policymakers, and I think for some maybe it was a fear, but that it was going to increase utilization incredibly high. It actually has not proven to be the case. There's sort of modest increase of about 1.6% in the latest analysis of how much this newfound access to care has really increased utilization overall. For audio only, I talked about this a little bit, but just to put a finer point on it, it's much more common around the use of audio only, which is just, care over the phone, is much more common. And I don't think this is any big shock to folks here, but it's much more common for older populations who have probably less comfort level with navigating the, computer. So they are relying on their phones more to do audio only visits, and more common around among folks in rural areas. Again, because of the broadband and accessibility issues. And then, we do see it also more common among non-English speaking and minority populations and lower income populations. A lot of that probably also accumulates to not having access to high-speed internet and things like that. We are expecting, more evidence for, to be more research to come out over the next several years around audio only and what are the impacts on quality to care, et cetera. This was something that was very, very rarely allowed for before the pandemic and has become a huge part of the way that care is delivered today. And very limited research existed about, what kind of, how good that care was and what was the impact of that kind of access to care. So basically the research community is sort of playing catch up on that at this point. And this is sort of in the weeds, but as folks who deliver that care and bill for it, one of the reasons that it is hard to look at audio only visits compared to two-way video visits compared to in-person visits is that a lot of the coding in the way that those visits were coded for, especially during the pandemic, were very mucky. So really hard for researchers to see what does it actually mean to have an audio only visit versus a video visit, because the coding was not very clean. On teleprescribing, I think I talked about this a bit already, but we have, as BPC, really come out in favor of teleprescribing for things like buprenorphine. There has been a lot of research to show that it decreases risk of overdose and that patients have positive experiences with virtual visits for prescribing buprenorphine. And there's excuse me, a current bill pending in Congress to make permanent the virtual prescribing abilities without an in-person visit. And like I said before, the DEA is also, there's a new proposed rule that is pending to be released that could also change some of these teleprescribing flexibilities. And then I'll end with just for this slide on licensure, which is another big area that folks or policymakers are thinking about. And as you all know, to practice in any state for every profession, there's a license that you need to hold and be in good standing with your state. And during COVID, almost every single state and the federal government allowed for cross-state services to be delivered without, so there were just waivers of these licensure requirements. And many patients were able to receive care across state lines because all care at that point was also mostly virtual. And since the pandemic, almost every state has gone back to the requirements pre-COVID. And those waivers have expired. And many patients with out-of-state providers, what they have found is actually stopped, instead of returning to or going to an in-person model, going to an in-person visit, they've actually stopped seeking care altogether rather than transitioning. And so that has a lot of implications for, what are these dynamics that we're sort of toying with at this point, which is if you're trying to get people back to in-person visits, simply turning off the accessibility is not actually maybe enough to drive that. It actually ends up that people are not seeking care anymore. So I wanted to say one more thing just on in general, and especially for this audience. So, you know, we also think a lot about the providers participating in value-based payment models and what are their incentives when they're delivering virtual care. And I think those providers have sort of the best aligned incentives to deliver higher value uses of telehealth in their practices. So if you think about, you know, this is true for a lot of what is going on in a value-based payment model, but, you know, as a provider that's participating and being incentivized on overall cost and overall patient outcomes, they're more able to think through, you know, what are the highest value uses of telehealth and audio only and teleprescribing, and where they can kind of turn that on within their practice. And so within BPC's, the Bipartisan Policy Center's recommendations, we do and have for many years supported full flexibilities with no sort of with minimal and, you know, guardrails, and if any, on what restrictions you have about accessing, you know, audio only or giving for your patients audio only services, teleprescribing without an in-person visit. So maximizing for providers that participate in APMs, the ability for them to choose when and how to use telehealth with their patients. And I'll go to the next slide. And so this really just highlights what I was saying earlier, which is that behavioral health services are an ever increasing share of telehealth services over time. And you know, a lot of that is because of the way that the modality just lends itself, and more people are opting into I think what the evidence is showing is more people are opting into behavioral health care because of the minimizing of the friction of trying to like get access to those services. So, you know, be curious to hear from you all if this is true in your experiences about how you're perceiving the types of services that are provided in your health centers and clinics. But what we see overall is a big growth in as a proportion of telehealth services, that behavioral health services continue to be a growing portion of that. Go ahead. And I think, you know, one of the things that members of Congress and the administration have really wanted to understand, because you don't want to create sort of misaligned incentives. Yes, behavioral health services are easier to deliver virtually, and, you know, may not need an in-person like loop to happen. But what you also don't want is, as a policymaker, you don't want to create an environment that preferences only virtual, and that can lead to sort of a shrinking of the availability of in-person visits for behavioral health services, because there are always going to be people who need to come in person, especially some of the more, you know, acute SMI patients. I mean, I've talked to a lot of clinicians, and there is a limit to like the kinds of patients that you can just exclusively deal with on a virtual platform, right? And as you create more and more favorable conditions for behavioral health clinicians to continue to deliver services virtually only, the fear is that those clinicians will, of course, you know, all kind of give up their physical locations and start to virtually work only virtually, and what that might do to and mean for people who need to come in person, and what is the availability of actual in-person care at that point. So what folks have looked at, MedPAC has looked at, is really what is actually happening on the ground? What is the share of clinicians who are exclusively delivering virtual services for behavioral health? And you can see non-behavioral health services is on the left. And over time, from 2020 to 2022, that's basically remained unchanged because, as I said, like, you can't give up a physical location and just exclusively move to virtual as a pediatrician or a family doc. You got to have a physical location. But for BH, you do see a huge change. And the gray at the top is what has happened with the COVID related flexibilities. So from 2020 to 2021, we see a change of from 4% to 26% of behavioral health clinicians that operate only virtually. And one thing to note is that from 2021 to 2022, that starts to tick back. So, could speak to the fact that behavioral health providers can more easily move back into and have physical locations, but we don't necessarily know where that gray bar will end up given the current flexibilities. I think I have one more slide. Great. Okay, I think this is the last one around telebehavioral health, just to give folks an idea. Another issue that BPC does have a policy point of view on this as well, and that is for people, let me say it this way, Congress did act to say that you have to have an in-person visit before receiving a virtual telebehavioral health service, but that requirement has continued to be waived since COVID. So it's never actually gone into effect. And what this is trying to show is how, if it were to ever get flipped and go into effect, how many patients would that change, which is in statute, how many patients would that change potentially disrupt the care of? So BPC has a position that we shouldn't, that requirement should go away, and that requires, for it to go away completely, it does require a change to the law. And what this is showing is almost half of beneficiaries with a telebehavioral health visit in Q4 of 2022, they had a preceding in-person visit with a provider or someone in that same group with that provider within the past year. So that would mean that if that requirement went back into effect right away, about half of beneficiaries their care would be disrupted, because they would have to go back to make sure that they get to an in-person visit before they could continue having virtual visits with that provider. And that, that's a big deal, because we don't know how many of those people would actually be able to go through with it, or they would let their care lapse. So with that, I think I have made it through this section of slides. Oh no, I have not. I'm going to go through these pretty quickly because I feel like I've talked for a long time. So we have several recommendations, and I'm just gonna, I'll share with this group the full report, but we did just recently release a report around what the federal government should be doing and Congress should be doing around telehealth policy. Our report came out last month, and we have two main big picture, at the umbrella level here, theme. We really do believe that Congress has to establish a more sustainable long-term telehealth reimbursement strategy, and that may or may not end up being parity. But what they do need to do is ensure that an exercise happens to see what is the cost of delivering these virtual services, especially in hybrid models where the provider has a physical location as well as is continuing to deliver virtual. And if that ends up being parity, great. But if not, we do need to make adjustments to what is the reimbursement long-term for virtual care. And the second big bucket here is around ensuring that the care that we do deliver virtually, which will continue to be a big portion, at least for behavioral health, is of high quality. And that is going to require some more investments around the kinds of training that we give providers and how to deliver care virtually, and more investments around monitoring fraud, waste, and abuse. And I think I did actually, when we just go to the next slide, I'll get into that in a little bit. But I think overall, there is a couple things within how to improve the quality of virtual care. So long-term reimbursement strategy, I already did say this, but CMS has to figure out what is going to be what is currently the cost of telehealth for providers, and commit to a long-term reimbursement strategy. And the next one. And then for high quality virtual care, I think the one that I want to highlight is actually just around prescribing of controlled substances via telehealth. So I think from what we have heard, and we talked to a lot of providers and medical specialty societies, there is, it is great to improve the access of especially things like buprenorphine, and make sure, given the overdose rates, especially among young people, that is sort of mission critical to improve access to treatment, and given how few people are in treatment that have substance use disorder. I think the other thing to weigh, though, is that we have, we're standing sort of at this precipice of potentially what happened at the beginning of the opioid epidemic to begin with, which was really loose access to controlled substances that then set us onto this trajectory that we're living through the aftermath of today. And so I think for certain controlled substances, there is what we're hearing, and what the DEA has actually cracked down on, is certain providers that, a lot of them they're in the news today, but virtual only sort of shops, and they're advertising to kids directly and saying, come here for your Adderall, come here for your ketamine, come here for this. And that before COVID wouldn't have been allowed, but because of the current flexibilities that we have, that creates the environment for more of that to be happening. And I think there is a real cause for concern and a need to promote best practices among all clinicians for how do you prescribe controlled substances via telehealth, and also just additional in ensuring that the kind of operations that might be happening now for not good, not for the increase in access to patient care, but for sort of just generating their own income around, prescribing different controlled substances, that needs to be cracked down on. So I think now with that, I will end, and I'm sorry I went way over. Do you want to, since I did go way over, and I'm really sorry, do you want to go to questions now, or save everyone's questions until Kendall goes?
Pause for questions. I was just looking at the chat and I'm not seeing any. If anyone wants to come off mute
Great.
for a moment.
Now, why don't we go ahead and hand it to Kendall?
Sounds good. Thank you. It's hard to follow, Julia, but I will try my best. So for my part of the presentation today, we're going to be exploring the federal landscape concerning Medicare Part B physician payment reform. I'm going to focus on some historical context, a little bit of information on the recent actions from HHS and Congress, and then talk about the shift towards value-based and accountable care. And I will make sure to highlight things that are going to be particularly relevant for rural areas, rural providers. I will also include details on the movement towards value-based accountable care as it relates to behavioral health care integration, and specifically integration in rural areas. BPC does have specific reports on behavioral health integration just in rural areas if you're interested, but I'll highlight some stuff here. I'm also going to talk about the value-based care system as it sits within Medicare Part B payment structures right now, just to help tee up a larger conversation about where lawmakers' heads are at moving into the next Congress and the next administration and what we think reforms might look like. Following that, I'm going to talk about the focus areas for those lawmakers and regulators as they attempt to migrate more folks into value-based accountable care in Medicare Part B. And again, I'm going to try and highlight some of those topic areas that are going to be of interest to rural providers. And then to round out my presentation, I'm going to talk about where BPC's work is in these issues and where we think we're going to come out in the coming months. So, Molly, would you mind hitting the next slide? So the Medicare Access and Children's Chip Reauthorization Act, also known as MACRA, I'm sure you all are familiar with this, took effect in 2017 with the goal of rewarding providers for value-based care rather than on the volume of services they provided. The law was and is an attempt to transition from fee-for-service, aka volume-based payment, to alternative payment models, also known as APMs, to achieve better patient outcomes and also to spend federal dollars more wisely. Just a note here, I'm going to use the term value-based care to mean care with accountability for patient health outcomes. It's also called value-based payment, population-based models, total cost of care. I'm going to use them all a little bit interchangeably here, but please don't mistake that for me meaning that care outside of the system is not valuable. While the goal has been to get more folks into value-based care by 2023 per HHS, we have not made a ton of progress. There are a couple reasons why that has occurred, and our goal is that policymakers address some of these challenges and try and incentivize folks to transition more beneficiaries into value-based and accountable care. And the good news is CMS and Congress both seem really interested in doing this. For example, the Senate Finance Committee and the House Ways and Means Committee are both key players in the space. They have both held hearings recently on reforming physician payment, addressing administrative burden for providers, and talking about the evaluation of primary care services and other items traditionally valued in the Medicare physician fee schedule. And not only are CMS and Congress interested in this reform, but they are obviously considering the challenges and impacts for rural providers. If you were able to catch any of these hearings, or if you catch any in the future, it is very likely that you will see folks with rural perspectives giving testimony, which is really heartening. This is partially because, as you all probably know, rural areas tend to struggle generally with limited resources and smaller patient volumes. And this can be really challenging when we start talking about physician payment reform and system transformation. And that's also part of the reason why when we have rural providers who come talk to us or talk to Congress about moving into value-based care, we also often hear about tailoring incentives to support and encourage rural participation in value-based and accountable care models. Molly, can I have the next slide, please? Sorry if I'm going fast. Also, I know we only have 15 minutes left. For context, again, similar to MACRA, I'm sure you all are familiar with Medicare Part B physician payment, but just going to give a little bit of overview and a refresher. This is kind of how I visualize the system. Essentially, there's two parts. The first part is the traditional fee-for-service, which focuses on service volume. And then there is the quality payment program, which is what was created by MACRA almost a decade ago and tried to focus more on the value of the care provided by infusing accountability into that care. So in terms of the fee-for-service portion, the Medicare physician fee schedule, which Julia had already talked about, is released by CMS on a yearly basis, and it outlines payment rates for specific services. What is unique for our physician payment reform objectives this year at BPC, and I think in Congress, is that this year's physician fee schedule had something a little bit unique, and that was essentially a hybrid payment. So some of you may be familiar with this, but the concept of hybrid payments is seen as a way generally to infuse accountability and value into traditionally volume-based services. Right now, hybrid payments as proposed in the fee schedule are specific to primary care providers, and I honestly don't know what their future looks like. I think everybody's still trying to figure out how they could be helpful or unhelpful in terms of CMS's larger goal of moving more folks into accountable care or value-based care payments as envisioned under the quality payment or QPP. That being said, there's also a bill in the Senate right now. It's a bipartisan bill. It's called the Pay PCPs Act, which is another attempt to create hybrid payments within the fee schedule. Moving on to the other side of the payment reform, or sorry, the payment structure under Medicare Part B is the QPP as created by MACRA. That has two components. The first is the merit-based incentive payment system, and it allows for providers to essentially receive reimbursement adjusted based on their performance. As it stands right now, again, most folks have not moved into the quality payment program, but of the folks in the quality payment program, more beneficiaries and providers are remaining in MIPS rather than AAPMs. That being said, as time has passed, there's been a lot of red flags raised about the workability of MIPS and its sustainability and whether or not it should remain an option for offering value-based care moving forward. So while there haven't been any changes to remove MIPS right now, certainly there's been tweaks suggested to strengthen the program. CMS does plan to sunset MIPS into something called the MVPs, or the MIPS Values Pathway. There's not a ton of data about how it's going to work. CMS still seems to be gathering feedback on how this would work. But to me, I visualize it as a way to jump forward into the AAPM track, which is where CMS wants to go. Now, the AAPM track is advanced alternative payment models, and this is really the bread and butter of what MACRA is trying to accomplish. And this is providing reimbursement to providers for high quality and cost-effective care. AAPMs are generally tested by CMS's Innovation Center, or CMMI, and oftentimes they're only models and they're time limited and they don't have a ton of uptake because they are really specific to certain providers or populations, and they require a lot of initial resource investments and operational changes on the part of providers. What distinguishes MIPS from AAPMs is that in an AAPM, you're generally, or the provider is generally taking on more financial risk for their patients. A really popular AAPM that you'll hear about is an ACO, or an accountable care organization. This is what the Medicare Shared Savings Program is. There's the ACO REACH, the ACO Enhanced Track. ACOs generally require more coordination among providers across the spectrum of care. And they're generally more popular than MIPS because if they're done well, the financial rewards to providers are greater. Now, what's happening is that as we move along in time, the financial rewards for MIPS and AAPMs, there used to be a pretty good wedge between the two. But as time has gone on, the financial incentives for being in AAPMs is narrowing to be more closely aligned with MIPS. And overall, a lot of providers would tell you that it's narrowing to the point where fee-for-service might even make more financial sense for certain providers. In general, there's not 100% perfect data available about the use of these models, particularly when you're looking at where beneficiaries are assigned, what providers are using, because a lot of times you'll have a provider who is seeing Medicare, Medicaid, and privately insured patients. I know of one rural system where 5% of their contracts are in ACOs and the rest are in fee-for-service, or different arrangements just based on who's paying. This occurs for a lot of reasons, often because there's not alignment across payers, which is something BPC is going to seek to address in our upcoming work. But I'm sure you all have heard of different reasons this occurs. often because of variations between providers, provider sizes, particularly in rural areas with lower volume, patient populations and different patient needs, workforce ability, again, clinical workforce ability, which we've worked on separately at BPC, just getting some of those clinical workforce folks to, or non-clinical, quite frankly, folks to get out to rural areas is really hard, and that impacts the types of models that providers can actually deploy. The good news is that CMS has been interested in the last couple of years in really building out more AAPM models, as well as how different behavioral and mental health care models can be integrated into these models. Molly, can I have the next slide, please? I'm going really fast and it hurts reason, guys. The other good news is that policymakers seem as excited about CMS and engaging in this physician payment reform. And as Julia mentioned in the beginning, I think for macro physician payment reform, generally this remains true and will remain true into after the election, regardless of what party is in power. That being said, the extent to which I think it's a full Medicare physician payment overhaul, as in like another MACRA or just small tweaks, I honestly can't say, but my money would be on tweaks. That seems to be the sweet spot for Congress. Nonetheless, given challenges with the national debt, it is certainly prudent for lawmakers and regulators to talk about improving care, making it more high value, and saving money, even if the cost savings for value-based care may come down the line and may be outside of that like initial short-term kind of financial outlook that a lot of policymakers unfortunately have because they don't see the returns while they're in office. In any case, from our point of view, we think that the policymakers are going to address these three areas. One is incentivizing and accelerating participation in the advanced alternative payment models, including ACOs, which I mentioned, by considering financial incentives to boost participation. There's actually a provision in the current fee schedule, the Medicare physician fee schedule, for prepaid shared savings in the MSSP, which I also mentioned, which would help with upfront costs to providers and practices. We've heard a lot of good things about how valuable this upfront investment can be. The extent to which it can be deployed widespread is questionable. And then there's a lot of talk of reconsidering thresholds for participation in AAPM so that low volume providers and rural providers can actually take advantage of these value-based models. And speaking of rural providers generally, there's a lot of members of Congress, obviously, who represent rurally or partially rural districts who don't want their constituents and providers to be left out when we're looking at how we can address physician payment reform. The second item that we think policymakers are going to focus on are reducing administrative burden, particularly within the quality payment program and probably MIPS more specifically. We think this is going to look like, and this has looked like already from CMS, simplifying quality and performance reporting burdens, streamlining prior authorization processes, and trying to see if they being CMS can provide more stability and reduce data and reimbursement turnaround time to make financing for rural providers and providers across the board more consistent. And hopefully, although I think this is going to be a long-term project, is creating more of that multi-payer alignment. So providers aren't constantly having to submit all these different things to all these different systems, and then it changes again and again. And then last but not least, ensuring appropriate valuation of services in the fee schedule. As the graph on the previous slide that I had showed, fee for service and the quality payment program can be looked at as two sides of the same coin. A lot of folks believe, and I tend to agree, that value-based care, no matter what form it's going to take in the US and in our Medicare system, is going to depend on a really solid fee schedule. And there is general agreement that primary care services are misvalued and perhaps undervalued within the fee schedule. So for any type of reform to happen that improves care that has value infused in it, we have to look at our primary care system for it to be effective and really accountable. As an aside, I'd also like to point out that one thing we hear about is the challenges that providers are having. I mentioned it earlier with the hybrid payments, but folks don't know when they enter a value-based care arrangement, how long it will be sustainable for. And that's part of the reason that we're looking at Medicare physician payment reform, is because we're constantly hearing that changes are coming. Providers think that their changes are coming, and this uncertainty is really unhelpful for providers, whether you're a small independent practice or you're a larger health system. And I think it's often the reason why folks revert to fee for service, which I think is fine if it works for you, but if the goal is to really infuse value-based care and save costs down the line, I think it's going to be a big reckoning for Congress. Next slide, please. So as I mentioned in the opening of my presentation, MACRA, which created the Medicare Part B physician payment system that we see now, was passed in 2015, nearly a decade ago. Since that time, there's been a lot of turnover in Congress, and with that, a lot of turnover in institutional knowledge for lawmakers and for their young staffs about Medicare Part B physician payment policy. So to that end, our focus at BPC will be to develop some educational explainers and kind of raise the educational for new lawmakers coming in and their staff about physician payment reform. I think our focus is really going to match what I outlined on the previous slide. Again, growing participation in value-based accountable care models, addressing administrative burden, and then ensuring that the fee service is really rock solid in terms of how services are valued. I think we will also, well, I don't think I know, we're also going to look at behavioral health integration and rural needs as always, as well as equity and access for all Americans. And at the end of our project, we intend to have a handful of really actionable, pragmatic, and bipartisan options for policymakers. That being said, our work on this issue did not start with this project. As you can see on this slide, we've addressed growing the use of value-based care in rural areas as part of a previous report, and we do not intend for this work to end anytime soon. So in closing, I think the transition, what I'll say is the transition for value-based care within Medicare Part B, I think, is going to take a while, and policy reforms are going to be just as nuanced as policy now is complex, and the needs of rural areas in particular are going to be needed to be addressed just as carefully to ensure that rural providers are not negatively or inappropriately impacted. And like I said, I think Congress and specific members of Congress and on important committees are interested in this, which is great. So with that, I want to thank you all for your time with us today and open it up to any questions.
Feel free to come off mute, or I'm still monitoring the chat if you'd prefer to ask questions that way. I believe we're going to pull up our final polling questions while there's Q&A. Also, just thank you so much, Julia and Kendall, for presenting. This is a lot of information and some really, really good areas. So thank you again. Any questions from the group?
Seeing any in the chat at this point, but I do want to say to Julia and Kendall, thank you so much. What a great presentation, so much information. This was exactly what we were hoping for this. And so we may be inviting you back in the future. And again, thank you. And also it's good to know that you all have those papers and resources out there for the audience to access as well. But thank you so much.
Yeah, thank you for inviting us, and please feel free to share the deck with everyone that participated, and make sure that they have access to the reports and things. And to anyone in the audience, you feel free to reach out to us if anything comes up that you want to chat about. So appreciate it.
Thank you.
Thanks.
I'm not seeing any questions, but just a couple of reminders for attendees. You'll see a evaluation come through email. If you can take that survey, that's what will help you get the ACHE credits. And then we'll send out a recording and a copy of the slides too for you to share. All right. Well, if there are no questions, thank you all again. Reach out if you have any questions in the meantime.
Everybody, thank you.